Hello everyone, I'm very happy to be here today to present my progress on my PhD topic, IgA Vasculitis with nephritis, challenges and updates in the management of pediatric patients. First of all, I would like to summarize a bit our results from the first project. We started from the problem that up to 80% of patients with IgA vasculitis develop renal injury, and often they are diagnosed lately. Still, we are unable to identify the risk factors that precede this irreversible kidney damage. What we tried to do was to find biomarkers that can help us, and our meta-analysis showed that an elevated neutrophil to lymphocyte ratio, platelets to lymphocyte ratio, as well as the positive fecal occult blood tests are associated with renal involvement. This opens the way for further prospective studies that would validate these biomarkers based on their diagnostic performance and include them into predictive models. Also, the policymakers need to encourage more the biomarker-based diagnosis in this pathology. A few words about me. I'm a first-year PhD student and a second-year pediatric nephrology resident doctor, and on that slide you can see the lovely team that helps me achieve my vision of decreasing the chronic kidney disease burden in IgA vasculitis patients by improving their management. The first three projects that I started this year are listed here, and I want to talk about the first one more in detail, which focuses on investigating the predictive accuracy of serum and urinary biomarkers for renal involvement in IgA vasculitis pediatric patients. IgA vasculitis is a multisystemic disease which affects between 3 to 27 cases per 100,000 children. It affects not only the kidneys but also the skin, the gastrointestinal tract, and the joints. But this renal involvement is the most important because it is associated with the long-term morbidity and in up to 7% of the cases to end-stage kidney disease. We don't have evidence-based guidelines for diagnosis and treatment in this pathology, and one way to address this issue is by working towards a better risk stratification by using, for example, biomarkers. This is why we aim to identify predictive serum or urinary biomarkers for renal involvement to limit renal complications. This is the clinical question we started from, and we hypothesized that the NLR, KIM1, and NGAL can predict the risk for renal involvement. If this proves to be true, it will mean for the clinicians that they will have the opportunity to do a better risk stratification and an earlier tailored interventions for their patients. Also, it opens the way for international trials to validate the risk score in this pathology. We started from this search key in November 2024 and obtained around 7,000 articles, from which we selected 98 eligible full texts. Also, we performed a forward and backward citation chasing step and obtained other 30 full texts that were eligible. This is the summary of the first project, how we went to each of the steps, and now we are in the manuscript writing phase. I would like to present you some of our results. The first one shows a forest plot of association between the NLR and renal involvement. The effect size in this case is the mean difference, and we are looking at the biomarker that is obtained by doing the ratio between the number of neutrophils and the number of lymphocytes. It has a normal range between 1 and 2, and an increase above 0.5 can be considered clinically relevant. This was already used in cardiovascular and oncological diseases, as well as in other autoimmune diseases. We analyzed 18 studies with around 2,500 patients. All of them are observational studies, retrospective and prospective ones. And as you can see, the heterogeneity in this case is quite high, is of 76%, that we tried to address by doing this subgroup based on regions because of the possibility of having some different genetic background. And also, we presume that there are some differences based on the way of determining these parameters and the definition of nephritis. We compared patients with and without nephritis and obtained a pooled mean difference of 0.48, meaning that the NLR is higher in patients with renal involvement with 0.48. Still, when we are looking at the different subgroups, we can see that in the Chinese subgroup there is basically no difference between the two categories, while for the Turkish population we obtained both mathematically and clinically relevant result. Going further to the PLR, which is the ratio between the platelets and lymphocytes, in this case we have again the mean difference. And the normal range of this parameter is between 60 to 120. A difference of around 20 can be considered clinically relevant. We analyzed around 2,000 patients, and in this case, the heterogeneity is moderate of 49%. That also can be explained by these regional differences and also the differences in the nephritis definition. We obtained a pooled mean difference of 8.76, which means that the PLR is higher with 8.76 in patients with renal involvement. Again, if we are looking at the different subgroups, the differences are very evident. In the Korean and Turkish populations, the difference is clinically and mathematically significant toward the higher PLR in patients with renal involvement, whereas for the patients from the Chinese subgroup, the tendency is toward higher PLR in patients without renal involvement. And the last forest plot shows the association between the positive fecal occult blood test and risk for renal involvement. It is already known that the presence of gastrointestinal involvement predisposes the patients to the appearance of nephritis, and this is why we looked at this biomarker. We looked at around 800 patients from 4 prospective studies and obtained an odds ratio of 2.04, meaning that patients with a positive FOBT have a 2.04 times higher odds of developing renal involvement. All the other outcomes are summarized in these tables. Most of them are not clinically relevant nor statistically significant. We have a lot of them, but those were the most important. Our strengths are that we analyzed 41 biomarkers and we looked at different ethnicities and a large number of patients, whereas we are limited by the lack of data on the diagnostic performance information about these biomarkers and the retrospective designs of the majority of included studies. We can conclude that the elevation of NLR and PLR as well as the positive FOBT are associated with renal involvement in patients with IgA vasculitis, and this can open the way for future studies on analyzing the diagnostic performance of these biomarkers and then include them in predictive models. We are in the manuscript writing phase, and we wish to finish the first draft by the end of this week. Going further to the second project on investigating the predictive accuracy of different histological classifications for renal outcomes in pediatric IgA vasculitis nephritis, where we will use the same systematic review and meta-analysis methodology. As I already mentioned, nephritis is the most severe manifestation of IgA vasculitis and is responsible for long-term morbidity. Still, the guideline from 2024 recommends treating our patients based on a histopathological classification from 1977. What is the problem with this old classification? It focuses only on the active glomerular inflammation and neglects the vascular and tubular interstitial changes, while the proportion of sclerotic glomeruli and interstitial fibrosis are actually better predictors of long-term outcomes. How we can address this? By looking at other classifications that were previously used in IgA nephropathy and check if these are, have a better predictive value in establishing the severity of IgA vasculitis nephritis. This is the clinical question we started from, and we wish to use the PIRD framework to compare the different histopathological classifications available with the recommended one, the gold standard one, the International Study of Kidney Disease in Children classification. We hypothesized that the newer classification predict the renal outcomes better than the old one, which will mean, if it is true, to have at hand a more comprehensive histological classifications and the better therapeutic management for these patients. Still, multicentric studies will be needed to validate a new histopathological score. In summary, these are the 3 projects that I started in my first year of PhD studies. The first 2 ones are focusing on IgA vasculitis pediatric patients, whereas the last one is a neurostat analysis looking at a broader population of adolescents and young adults with chronic kidney disease. Also, I would like to mention that the results of our first study were accepted to be presented at the European Society for Pediatric Nephrology annual meeting in October this year. And I would like to leave you with a quote from the Romanian gymnast Nadia Comaneci, who said, "Enjoy the journey and try to get better every day. Don't lose the passion and the love for what you do." And I think this is what should help us go further in our work. Thank you for your kind attention.
I have one question related to the first topic. So you made subgroups based on different nationalities, China, Korea, and Turkey. Is there any particular reason why you did that? I mean, for example, is there any significant difference between the incidences?
Yes, actually, in the Asian population, the incidence is higher compared to the European population.
I see, but you had subgroup from China and
Yes.
Korea. Is there any significant difference?
Yes. Actually, from the incidence point of view, there is no difference. This is why at the beginning we started by doing the regions-based subgroups, Western Pacific region and the European one. And then we realized that there were two studies, the studies from Korea that seems to be some in a different direction from the other ones, and tried to find the reason why. And probably there is a genetic background that is different, even though both populations are Asian populations. It seems like the Korean population has some polymorphism that predispose them to a more severe course of the disease compared to those from China.
Okay, and my other question, could you analyze biomarkers in a combined way, so not only separately, but also with combinations?
We wanted to do that, and we asked for individual patient data from the authors of the articles, because we couldn't do combined analysis based only on the data that were published.
And did you get that?
We got it just from 7 authors, and the data...
How many?
7 articles, but still we didn't have...
it's not that bad.
Yes, but still we didn't have that many biomarkers, and the most promising ones were not included in those data that we received. So we weren't able to do this type of analysis, unfortunately.
And could you do any additional analysis from these individual patients' data? I mean, 7 studies in the individual patients' database, it's not that bad, not at all.
Yes. We just used those data for the mean differences calculation, because in the articles the data were not present, so we could do those mean and standard deviation to add it to the other data that we already had from the articles.
I have a question. I know that you focused on the biomarkers and finding the early onset, but I'm curious, like, what would be the treatment or something that you would do as a pediatrician to prevent the renal problems?
Well, we can't treat them. There's no preventative treatment, but still we can do a more stricter follow-up, because it is very important. In those patients, they have a rash. This is what the parents see, and some of the parents just consider that if the rash went away, there's no need to come to the doctor. Well, when we know that those patients are at risk for renal involvement, we can make sure that those patients are coming regularly. It is recommended to have a urinalysis every week in the first 3 months if the patient is at risk, and then if there is no change, we can do it in a more I don't know, like a longer time frame between the follow-up visits.
I have a question regarding your first project. We saw that for NLR and PLR, the results were different for the different countries. And based on this, would you recommend these biomarkers for clinicians?
Well, we can't actually recommend them because we don't have the diagnostic performance data. So we can't make recommendations for the clinicians to base their decision on our findings. Still, we did the first step towards having biomarkers be used in this pathology, because now we can researchers from all over the world can do some prospective studies and focus on these selected biomarkers, because as you can see, there were a lot of biomarkers that were studied. Some of them are very easily accessible ones, some of them are more preclinical ones, let's say, and the results show that those preclinical ones don't work yet, but these ones, maybe they can be used, and we need the diagnostic performance data to decide on that.
Still on the same topic of NLR and PLR. These biomarkers are dynamic ones, so their value may change over the course of hospitalization. Is there any difference between the countries that you subgrouped by, between the time elapsed between symptoms notice and blood sampling?
Well, we don't have very exact data. In theory, they say that they are taking the blood samples at the first admission of the patient in the first day of admission. Still, we are not so confident about it, and this is why one of the reasons maybe for the heterogeneity, because it might be a difference if a patient, for example, goes for first at a smaller hospital, at a county hospital, and then goes to a tertiary care center, and these studies were all done in tertiary care centers. So maybe those patients were actually evaluated at the beginning of the disease, actually earlier than the moment when they were included in the studies.